next speaker is Katherine Luzuriaga, who will talk to us about can we eradicate pediatric HIV infections. Katherine is from Tufts University, has her degrees from MIT and her MD from Tufts University. She is currently the professor of pediatrics and molecular medicine and chief of the division of pediatric immunology, infectious diseases, and rheumatology. Now, she's had a lot of positions within the NIH, particularly the Pediatric AIDS Clinical Trials Group, and she's really committed to training the next generation of scientists. She's been recognized for her research on the transmission of HIV from pregnant women to their newborns and for how to deal with those infections. I'm really pleased to invite Katherine to the podium.
Thank you, Rita. We had a technical issue here, but I think it's resolved. So I'd like to thank the board for inviting me to speak. I think this has been truly an honor to participate with you in this fabulous symposium. And it's particularly meaningful because I think that, as many people have alluded to, there are so many accomplished women in this room who, through their work, are really pushing science and the perception of women in science. And just to tell a story, my work has taken me to many places, including Liberia, which just emerged from 20 years of conflict, and it was led out of the conflict by the first female head of state in Africa, Ellen Johnson Sirleaf. And in one of my travels there, I was speaking with a colleague who related a story of asking his 4-year-old nephew what he wanted to be when he grew up, and that 4-year-old kind of was thinking for a while, couldn't really come up with anything, and was prompted to, by my colleague to say, well, what about president? Would you like to be president? What do you think about that? And his response was, I don't know if I can be president. That's for women, maybe vice president. So I think, again, the power of example is so strong, and I thank all of the women here for what you're doing to change the perceptions. So what I'm going to do is talk about my adventures as a physician scientist and give you my perception of just the fabulous advances in the area of HIV/AIDS that have come about through participation of people across the science spectrum, and that's advances in basic science, translational scientists, implementation scientists, outcomes experts. So we'll go ahead and try to move through this pretty quickly. So I think many of you know that HIV/AIDS, the first cases were described in the early 1980s, and in the 30 years since then, there was pretty quick identification of the causative agent and development of testing. And since then, because of several technologic advances and basic science advances, we were able to understand the viral life cycle, develop antiretroviral agents, apply those in the clinic, and there have been some real advances in terms of prevention, and now we're actually saying the C word, which is possible cures. So, but in 2012 and 2013, there's still a lot of work that remains. There are 35 million people living around the world with HIV, 32 million of whom are adults, and about 18 million are women. So about half of the infected people, of individuals around the world are women. 3.3 million infected children. There are 2.3 new infections each and every year, of which 260,000 occur in children, 1.6 million deaths, 200,000 deaths in children each and every year. So despite these tremendous advances, we still have a lot of work to do. So my personal journey began with a patient. And as a young fellow, I went into the clinic and saw a 6-month-old boy admitted with fever and respiratory distress. He was very small for age, had a lot of swollen lymph nodes, big liver, big spleen, and unfortunately, this presentation was very characteristic of presentation with a child with AIDS in the late 1980s. We did a tracheal aspirate that did show he has pneumonia by x-ray. He's got pneumocystis in his lungs, started him on treatment. He, after doing HIV antibody and culture, he did well for a while, but those were the very early days of the epidemic. We had one drug to offer, and unfortunately this boy succumbed at a few years of age. So, you know, as a pediatrician and then as a parent, it became very, very difficult, I think, for me to go to the clinic repeatedly and to see this. And so fortunately, at that point in time, I was training in laboratory techniques in immunology and virology, and started going back and forth between the clinic to try to really understand a few things. And some of those very few things that we understood was, number one, the role of viral replication in the disease process, and that made it important to really try to get antiretrovirals in to the clinic as soon as possible. Now, mother-to-child transmission is the primary mode of pediatric infection, and so some of the efforts in what we understood in the late 1980s was that we really needed to get antivirals into women and offer them to women in order to optimize our chances at not only preserving their health, but at preventing transmission to babies. And what you can see is that in the absence, this is from a particular study, the transmission rate in the absence of antivirals there was 20%. It can be anywhere from 20 to 40%, depending on the cohort. With zidovudine alone, in the early 1990s, we were able to bring down transmission by 2/3. And then as we got more and more antiviral drugs and started using them in combination, 2 combinations halved it from the AZT alone, and then we were able to drive that down even further by using 3 or 4 drug therapies. And so by identifying women during pregnancy who are HIV infected, giving them antivirals, we were able to not only preserve mom's health, but also to prevent transmission to their babies. Now, one of the, I think, big techniques that really drove HIV care was the availability of the polymerase chain reaction in the late 1980s. And we were able, and others, I think Alice certainly has some publications on use of PCR in culture for early diagnosis. And so what we did, I think many of you may know that women who are HIV infected make antibodies. That's the most common way we diagnose HIV infection. But during the last trimester of pregnancy, moms transfer a bolus of antibodies to their babies, and so while not all women transmit the virus, all women will transfer the antibodies. So antibodies can't be used as diagnosis. So we then had to go to techniques that actually detect viral nucleic acids. PCR allowed us to do so on the very small blood volumes available from babies. And when we did that, we saw 3 general patterns of infection that we thought indicated either infection in utero or during gestation, infection during delivery or intrapartum, or infection through breast milk. And the in utero pattern, babies were positive at less than 48 hours and then had increasing amounts of viral nucleic acid in their circulation over time. In the intrapartum, the babies were uninfected, were negative at less than 48 hours and then positive. And breast milk transmission, which doesn't occur in the United States because we have safe affordable alternatives to breast milk. But in low resource settings where not breastfeeding can be a death sentence for the baby, breastfeeding is still encouraged, and those babies can be negative for many months at a time and then become positive. So really this ability not only to detect but to measure HIV was important in helping us to understand the timing of infection and the role of viral replication in disease progression. So with all of the advances in resource-rich settings, we've been able to drive the numbers of transmissions from moms to babies in North America, Western and Central Europe, Australia, down to very rare events. However, there are still a number of transmissions, as I said, about 250,000 each and every year, and most of those occur in limited resource settings such as Sub-Saharan Africa. So, this is a very complex slide, but I'll have you focus on a couple of areas, and we talked about most transmissions occurring in Sub-Saharan Africa. A lot of this has to do with, again, very limited resources, very limited infrastructure, but you can see also that in North Africa and the Middle East, there's very low rates of testing that have been very difficult to budge, and Shireen talked this morning about the continued role of stigma in impeding care, engagement of women into care and getting treatment, and I think that's very, very important. So efforts are really ongoing to push getting women into identified as HIV positive, getting them into care for their own health, as well as to prevent transmission to their babies. So maybe we'll go to the next slide just to move along. So those efforts are continuing, but we had another real problem on our hand, which was that the tempo of disease progression in babies was much more rapid than that in adults. And these are data from a meta-analysis that Marie-Louise Noel did in Africa, and what she showed was that in resource-limited settings in many areas of Africa, that 1/3 of HIV positive babies will die by their first birthday, half will die by their second birthday, and 3/4 will die by their third birthday. So if we wanted to do something about this, we didn't have a lot of time to wait. We had to apply our early diagnosis techniques and create some solutions for these babies. Go ahead. So in the early 1990s, with the availability of 3 and 4 drugs, with the first 3 and 4 drugs that were available, we started to do early treatment trials in babies. And these trials were, I think, important in showing that it took quite a bit, because babies tend to run higher viral loads, and that's probably because they have a lot of substrate. They also are less efficient at generating the HIV-specific immune responses that can control the virus, that 4 drugs were better than 3 drugs in producing prolonged response to therapy. And very interestingly, the babies who started therapy at less than 3 months of age did better than the babies who started at greater than 3 months of age. So this was the basis for a randomized clinical trial that was done in South Africa that showed that early treatment, again within the first few months of life, conferred marked survival advantage for babies. And as a result, the Department of Health and Human Services and WHO have revised their guidelines to recommend diagnosis and treatment of babies as early as possible. There's still a lot of operational issues here. You know, PCR is very difficult to implement in Africa, requires usually a lab and highly skilled technicians, a reagent chain. But there's some really novel things, point of care testing technologies that are being developed. We have an SBIR to look at developing one. And so I think hopefully we'll be able to push that envelope. Go on to the next slide, please. Now, all of these early treatments may help babies to control viral replication over the course of their lives, but they don't eradicate or cure the infection. And that's because HIV is a retrovirus, carries its genetic material as RNA, it's reverse transcribed, and then the double-stranded DNA is integrated into the host DNA. And that forms the barrier for cure. So in order to, once enough of that happens, you really have, you have to find some way to flush that DNA from the cell in order to effect a cure. So many of us have been interested in how we might cure individuals. This was the first, actually almost a serendipitous event in HIV, but came about because somebody made a very conscious and important choice. So this was Timothy Brown, who was HIV positive, developed leukemia. And I think many of you are familiar with the story that his physician made the very kind of interesting and courageous choice to recommend both bone marrow transplantation and to use cells that did not that were homozygous for a deletion, such that the co-receptor for HIV was not expressed on the surface of those cells. So that basically rendered the donor cells resistant to HIV, most forms of HIV infection. Well, this Timothy Brown underwent 2 bone marrow transplants after extensive conditioning that involved chemotherapy, irradiation, and then he got the stem cell transplantation and had extensive graft versus host disease. Now it's about 5-6 years post-transplant, and he has remained without viral rebound, and so really stands as the one case of cure in almost 70 million cumulative infections. Now, bone marrow, this is a really important proof of concept study, but bone marrow transplantations are very expensive, and as you can imagine, not logistically easy to accomplish in very limited resource settings. So many of us have tried to look at what we can do with available antiretrovirals, and again, another kind of serendipitous event allowed us to examine this. And this was a case of what has been called the Mississippi baby, which was a case of a baby who was presented in a rural Mississippi hospital. The baby was born at 35 weeks gestation to a woman who hadn't engaged in prenatal care. And so her HIV status wasn't known. When she presented to delivery, they did a rapid test, kind of like a home pregnancy test, same idea, and determined that the woman was HIV positive. But because of a precipitous delivery, the delivery proceeded so quickly, they didn't have the opportunity to administer the routine antivirals that we would do in such a case. The hospital called a colleague of mine, Hannah Gay, who basically does pediatric HIV care for the state of Mississippi, and she recommended immediate therapy with 3 drugs. Unfortunately, that hospital didn't have them, so the baby was transferred up to Jackson, University of Mississippi Medical Center. Hannah obtained the routine bloods that she would do in order to diagnose infection and started the baby on 3 drugs by 31 hours of age. Now, I will say that at that point in time, the expert guidelines did not recommend 3 drugs. They recommended 1 drug. And they now, the 2012 guidelines recommend 2 drugs. But if any of us were working in a healthcare setting and we received as significant exposure as this baby did, baby comes through the birth canal, the baby's bathed in blood, cervical fluids, that's just got tons of HIV, I mean, we would get 3 drugs. So that's why many of us thought that babies like this need 3 drugs. So to make a long story short, a number of different studies were done to confirm maternal infection, and mom not only was HIV infected, but when we actually looked at her virus in the lab, because a lot of questions came up in our presentation of this, those particular viruses were fully replication competent. So not only was she infected, but she had vigorous virus that was able to replicate well in vitro. The baby was diagnosed as infected because the HIV DNA was found in the blood, one blood sample at 30 hours, and RNA was found in the blood at 31 hours. And that alone makes the diagnosis by DHHS guidelines for pediatric HIV infection. But the baby actually had 3 other samples in which HIV RNA were detected after the initiation of treatment. And so this baby had a total of 5 samples, which more than met the diagnosis for the criteria for diagnosis. And I emphasize that because that was one of the big questions. I think when we came out with this, as with anything in science, you know, there's a healthy amount of skepticism, which is healthy and really is important. So this baby, no question, had multiple positive samples for that in which nucleic acids were detected. However, once therapy was started, the amount of RNA in the peripheral blood, and which represents virions, decreased rapidly, and the baby's RNA fell below the level of detection of the routine clinical assays. And the baby continued to do well clinically and continued to have undetectable levels of RNA until about 15 months of age, when the baby left care. The family had social issues, wasn't able to make it into the clinic, and so disappeared from care. And in retrospect, the mom said that she had discontinued antiretrovirals at 18 months of age. Hannah did her best to get the baby back into treatment, and the baby was brought back in at 23 months. Hannah did what we all would do in that circumstance, which is, again, a viral load or RNA to see how much virus there was in the baby's blood, see what the CD4 was, see whether there was any resistance, and plan to put the baby back on treatment, but then got the very surprising results that, again, HIV was undetectable, and this was now off treatment. And that is really, really an unusual, anybody who's treated HIV infection realizes that that's a very unusual course. Again, you know, babies usually require antiretrovirals to control infection over the first 2, 3 to 5 years of life. So Hannah retested the baby, and when that came back negative as well, gave me a call because she just, you know, didn't understand what was going on. The results were so surprising. And what we then embarked on was a whole panel of with another collaborator, Deb Prasad, another whole panel of very sensitive virologic and immunologic assays to find out whether we could find traces of the virus. And long story short, by routine clinical assays, we weren't able to. This baby does not have persistent HIV-specific immune responses, but continues to have, using very highly sensitive techniques, occasionally detectable viral nucleic acids in her peripheral blood. The baby is now 3 years of age, though. Has been off antiretrovirals for 18 months and still shows no signs of rebound. So this was a surprise and, you know, maybe a functional cure, but I think clearly we don't know whether those continued detections of viral nucleic acids are false positives because we're working at such a low level, or whether they truly represent virus that at some point in time may be replication competent and may be able to reignite HIV replication. So, you know, through a number of different observations, what we've proposed is that very, very early treatment. Why did this work in this baby when this hasn't worked? This hasn't worked elsewhere? And we think the key was the kind of the use of 3 drugs, so heavy-duty therapy, very, very early on. And what we believe that we did was not only decrease the total number of CD4 T cells, that's the reservoir, major reservoir, but also the number of long-lived memory cells that are infected with HIV. Babies aren't as efficient at generating memory CD4 responses, and so we think that actually works in their favor in terms of HIV. So if we can initiate treatment and really control viral replication before that reservoir becomes established, we may be able to treat babies for shorter periods of time. So, and we have a randomized, we have a non-randomized, clinical trial, but larger groups to see if we can replicate this, because as anything in science, replication is really very important. So, and we'll go maybe 2 more, next slide and the next slide. So I think we're doing a lot more work to really understand this piece of serendipity, but I will tell you that there is at least one other baby that I know of that seems to be very similar to the Mississippi baby that you may hear about very soon. But this has really been a tremendous experience as a physician scientist to be able to participate in this whole kind of experience of working with basic scientists, clinical scientists, implementation scientists to ensure that the fabulous scientific discoveries that have been made over the past several decades can be translated into benefit for patients and populations. And I'll just end to say that it has really been a fabulous experience for me. This is my recap of the many rewards of being a woman scientist, and it really is taken, it's not showing up, but this is from Alice's, a commentary that she did in Science in 2011 that was called Why Bother? And I think she, Carol Weiss, who I think is here to speak, said it very well. And it's just, you can't believe you're paid for this, right? I mean, it's fun to do. So it's the ability to ask questions, develop experiments to answer them, learning something new, and it's just a fabulous and rewarding and gratifying profession. So there's a lot of pleasure, intellectual stimulation, involved in working with smart, committed colleagues, particularly women, to make a difference. I've received fabulous mentoring, both from men as well as women, and can't underscore the importance of that. And it really has been a joy to try to pass that along. I don't know that I've always been the best mentor, but I try. And finally, I think Alice discussed just the fabulous range of opportunities that are available to scientists, because I think in training in the scientific process, there's just this kind of methodology that we learn and these sets of skills that we learn that are so applicable to so many, to a range of things that can be done. So I think I'll stop there and just go finally, as scientists, I think we have to be, very few of us work alone. I'd like to acknowledge Deb Prasad and Hannah Gay. I think we'll hear tomorrow about the fact that patients and the communities are very important partners in science, and so we really have to acknowledge them. It takes a lot to be a participant. Lots of laboratory collaborators, and we talked about the importance of our guys in being successful women scientists. My husband has been a fabulous partner, and I have 2 boys who cook dinner and wash the dishes, so so that I can come home late. So thank you very much for having me here.
Yes.
This new baby, was it also treated with the 3 drugs?
Yes, yeah. So, yes. Mm-hmm.
Yes.
Is the baby still alive?
Oh, the Mississippi baby. Oh, yes, 3 years old, doing very well, no controlling HIV, no rebound.
Terrific.
Off antiretrovirals.
After many disasters, finding some successes.
Yes, well, that's science, you know? Yeah,
Exactly.
you just have to keep pushing.
Exactly.
All right, thank you.
Thank you very much, Katherine.
Okay.